Hey everyone, it's Nicole Clark again with Health Pro Heritage QA and Compliance Team. Happy Halloween. I hope everyone is having a great day today. I know I'm looking forward to trick-or-treating with the kids tonight and eating a little bit of candy. I also hope you're able to have a little fun with your residents today. Today for the Right Way Wednesday, I wanted to talk about another one of our documentation training tools that focuses on dysphagia therapy. Here it is. As with all of our other tools, this one pulls information directly from the LCDs and other valid sources to give you a comprehensive review of the guidelines surrounding this treatment approach. So it's a really great tool, very comprehensive. So let's talk a little bit about what dysphagia is. So the diagnosis of dysphagia requires an extensive evaluation, right? So our evaluation must show that we've addressed every structure or assessed every structure. We've assessed each phase of the swallow. We've assessed appropriate diet consistency, right? It should be really clear. Unfortunately, I can't tell you how many times I've looked at an assessment over the years, not so much anymore, but it still does happen from time to time. And really from the evaluation through the discharge summary, I have not been able to figure out even what diet was recommended. So that's a really important point not to overlook in our documentation. And use standardized assessments when you're doing these. We tend to think as speech pathologists that our informal assessments are pretty objective, but in reality, they're really not. There is some inter-rater reliability issues and some variances, so we have to be objective. Okay, using objective measures to assess the swallow not only helps support the need for skilled therapy, but really helps you figure out how to drive your plan of care and develop goals. Right, it can really help you kind of focus and hone in on specific treatment strategies. So it's really important to not throw those standardized assessments to the side, right? And then sometimes we need more extensive evaluations like modified barium swallow studies or a FEES or something like that. So think about whether or not additional diagnostic information will be necessary following your evaluation. Right? And the treatment of dysphagia can include lots of different things, right? It can include simple recommendations for things like diet intake or even positioning, or it really can go much further. And that's what I really kind of want to talk about today, going beyond those simple techniques, which really only would require a couple of treatments and then moving on and transferring to a functional maintenance program, but thinking about a more therapeutic regime, right? Targeted at actual attainment of functional improvement, improving the muscles, improving the way somebody swallows, all right? So when you're looking at your documentation, I want you to think about some points, right? Have you documented a history of aspiration problems or definitive risk? Because that's really important when we're looking at swallowing. Even if the patient isn't showing overt signs and symptoms of aspiration, there should be, if we are treating them and providing skilled therapy, there should be some risk there involved, right? We need to be documenting that. Have we talked about, say, impaired salivary gland performance or the presence of local structural lesions in the pharynx, marked oral pharyngeal swallowing difficulties, really important, right? Is there discoordination, sensation loss, postural issues, other neuromotor disturbances? When's the last time we did a neuromotor exam? Okay, are those things affecting oral pharyngeal abilities? Maybe making it difficult to close the buccal cavity or bite or chew or suck or shape or even squeeze the food or the bolus into the upper esophagus while at the same time protecting the airway. Think about all of that. Is the patient post-surgical? Have we recently had a surgery that is impacting the ability to swallow? And why is it impacting that? Have we seen significant weight loss, and not just weight loss, but weight loss directly related to indicators of swallowing problems, all right, which is then reducing their ability to eat, and thus is a consequence of dysphagia. Is there evidence of other conditions, like the presence of a tracheostomy tube, or ventilator, or reduced laryngeal elevation, labial closure, velopharyngeal closure, laryngeal closure, or pharyngeal peristalsis, right? So, or some sort of cricopharyngeal dysfunction, all right? You notice how technical I got there? That is really what our documentation has to sound like. All right, it has to sound as skilled as our treatment is. And you've heard us say this before. Medicare explicitly says the services must be of such a level of complexity and sophistication that they can only be performed by a qualified, in this case, speech language pathologist. So if we're only documenting repetitive compensatory strategy training, or what and how much our patient ate, and whether or not any signs and symptoms of aspiration were observed, we aren't really documenting any skill. And I want you to think about it this way. Anyone who has been trained can provide cues to say use a chin tuck, or alternate bites or solids and liquids. Okay, anyone can do that. Anyone can document how much somebody ate and whether or not Miss Smith coughed. Our documentation has to show that treatment has gone beyond those repetitive tasks. So think rehab. How many times are we going beyond those typical oral motor exercises and training of compensatory strategies? Are we moving past them? Those are skilled to a point, but then very quickly at some point they become repetitive, okay? And we need to begin employing more skilled techniques, and that's what we need to be documenting, that consistent shift, that the fact that the treatment remains skilled throughout the entire plan of care. So think thermal tactile stimulation, right? DPNS, or some other technique that is designed not just to compensate, but rehabilitate those muscles. You know, I actually just signed up for a refresher on myofascial release for dysphagia. I don't know how many of you are familiar with that technique. I took the course years ago and was amazed. I had never heard of it before. I really thought the technique was great, and I'm going for a refresher now. But think about those kinds of things. Are we employing modalities like thermal stimulation to the oral cavity or gustatory stimulation? Are we considering neuromuscular reeducation when appropriate? Let's talk about that for a minute, though, because Medicare has a pretty clear stance in this area. And here's what they say specifically about vital stim in some LCDs, and Medicare or CMS does hold the same stance. They feel like, based on the review of the scientific and clinical literature, the efficacy and clinical utility of this service really does remain unproven. And I know there have been lots of studies, but there are some questions about the validity or the extensiveness of those studies just yet. All right, recent studies with the use of this kind of treatment, so neuromuscular electrical treatment, typically called vital stim, or that is the approved protocol at this time. Therefore, they remain unproven. So recent studies show sometimes a lowering of the hyoid bone during swallowing, which may actually be harmful to the patient if it's not placed properly. So therefore, Medicare at this time is not covering vital stim therapy on its own, and treatment is considered not reasonable and necessary when that is all that's being used on patients for dysphagia therapy. So, however, and they do note this, when used in conjunction with traditional dysphagia treatment, neuromuscular reeducation can be utilized during skilled treatment. It has to be used as a combination, and documentation then has to support the use of that traditional dysphagia treatment during every minute of billed time. All right, and vital stim itself, if you've gone to a course and have gotten certified, which of course you have to do before you even think about using it, does discuss those kinds of parameters. If you're a Health Pro Heritage clinician, we do have a policy for this, so we want you to review that before doing it or before employing that technique. That policy is Clinical 269. If you're a clinician with another company, please check to see what their policy is before performing any kind of neuromuscular reeducation for the swallow. All right, so yesterday we shared our tool in our documentation tool Tuesday, and here's just a quick look at it. It does even cover group therapy and some, as it relates to the Palmetto LCDs, and some guidance as far as what to bill for that. We are working on an additional tool that does provide some guidance for group therapy when looking at both dysphagia and speech and language treatment, but that is a work in progress. LCDs haven't typically given us a lot of guidance surrounding group therapy, both for speech and language and dysphagia. And so we are reaching out and trying to communicate directly with LCDs that really haven't provided a lot of guidance in this area, and As you may know, that does take some time if you've ever tried to contact them before and try to get some clarification on it. So that is a work in progress. We are working on that, but we are sort of at the mercy of the LCDs at this point, but we're trying to make sure that you have all of the information you need in order to bill properly. So just keep a look out at that for that. But if you are not with Palmetto and don't know what you should bill, if you are thinking about employing group therapy for your patients, because it can be a very valuable tool even with dysphagia treatment, you need to make sure that you do check with your LCD first and call your MAC if you need to, email them, or just check to see what the billing parameters are if they list those on your LCD. Okay, always check your LCD before you bill for anything. Okay. The last page of our tool, as with all of our tools, contains some great examples that compare what not to do with what to do in your documentation. So this is a great little cheat sheet, and not meant to just, of course, take what we write and put it into your documentation, but really think about how you're writing your documentation and compare it to these examples. So for example, instead of writing lingual oromotor exercises times 10 for 3 sets, swallow precaution training, patient required moderate verbal cues to use strategies. And as I talked about a little bit earlier in the video, that's not really skilled. Anyone really could have done lingual oromotor exercises with that patient. Anyone could have told that patient what kind of swallow precautions that they needed to use, and anyone could have provided cues to use those strategies. Nothing really necessarily skilled in the way that's written. So instead, maybe write something like targeted lingual strengthening exercises for increased bolus manipulation and oral transport, including lingual sweep, lingual elevation, lateralization, and lingual-based retraction exercises. Required therapeutic recovery period following 8 reps of each exercise for 2 sets, and tactile cues for lingual lateralization exercises. Training of safe swallow precautions, including slow rate, small bites, upright posture, and no straws with liquids, completed during therapeutic recovery periods. So we've gotten a little more specific. We've gone beyond general compensatory strategy training and documenting that. We've gone beyond just documenting that they completed the exercises. We talked about how those exercises affected that resident, what they were used for, what they were targeting. We've gone beyond those general, really non-specific terms. All right. And one more example before we go. Instead of writing patient consumed evening snack, soft sandwich with moderate verbal cues to use compensatory strategies, wet vocal quality noted. That's a lot about some observations of what the patient did and what the patient showed, but none of the skill. Okay? It's missing all of the skill. So instead, maybe documenting presented therapeutic trials of various upgraded consistencies, including mechanical soft meats and soft bread, using lingual sweep strategy training in order to prevent aspiration. Required verbal cues with 50% of bolus trials with patient exhibiting minimal oral stasis and left lateral sulci, and wet vocal quality following swallow without the use of liquid wash and throat clear re-swallow. Decreased signs and symptoms noted with the use of strategies and moderate verbal cues. Now, we could probably have gone much further in that and added some more skill, but again, these are just examples. And when you think about those examples and the difference between those two things, it's huge. Just much more detail, much more focused on function, much more focused on patient response and the clinician's role in that treatment. So I hope you found this helpful. As always, if you have any questions, please ask in the comments below or shoot us an email. As a side note, we would love to see some pictures of any teams that have dressed up for Halloween today. Remember, no patients in your photos, but we would love to see how you guys are having fun with your residents today. So if you have a picture of your team and you want to share it, you can share it in the comment box below or send us a post, and we'd be happy to share it with the rest of the page. Happy Halloween and happy documenting.